Okay, good morning all. So today we'll start with the endodontic surgery. Okay, so I think this topic has already been discussed in the third year of postings everywhere. So we'll go to the salient features of this topic, endodontic surgery. Okay, you're able to see the screen?
Yes,
Yes,
sir.
sir. Yes, sir.
Okay. So I will go to the salient features of the endodontic surgery. Okay, so you can see this X-ray already. It's got a good sufficient amount of root canal filling, but still there is a cyst. So this may be a case can be considered for periapical surgery. So what are the salient features of today? This thing is uh, the traditional endodontic surgery has been replaced, or it is only adjunct to the non-surgical root canal therapy. Nowadays, it is mostly adjunct to non-surgical root canal therapy. If you do the proper root canal, there is less amount of surgery performed. Maybe as less as 5% can be taken into endodontic surgery. And with the addition of operating microscopes, now it is most aptly called as endodontic microsurgery. Endodontic microsurgery. So these two things are there. So it is not like what it was practiced some 30 or 40 years ago. Now it is only adjunct to non-surgical root canal therapy. Second, with the advent of microscopes, it is aptly called as endodontic microsurgery, where you can do a very meticulous work and get a seal in the periapical region. So root resection or periapical surgery is the very commonest surgery because periapical cyst is the commonest one. And the objective is to ensure the placement of a proper seal between the periodontium and the root canal foramina. So as we all know, the rationale is to remove the causative agents. So I will go through all these slides. Maybe I will discuss about the salient features only. So curettage of the periapical affected periradicular tissue, surgical resection of the root, okay, to trace or remove all the accessory canals. So why we do this surgical procedure is to have the accessibility and visibility of the periapical region where it is not able to do it in the normal conventional root canal therapy. So the periapical surgery can be classified as root resections or orthograde with the root resection or periapical curettage, like that. Okay. So you go into the terminology. So episectomy commonly will get a short notes. So it is nothing but removal of the apical 1/3 of the root during resection to remove all the lateral canals, axillary canals, and to get a better seal and do a retrograde filling. Radisectomy is cutting off one root. Root intersection is cutting off the apical 1/3, and root in filling or retrograde filling is the same. And in other additions to that, we have hemisection, bicuspidizations, like all other procedures. So contemporary classification is incision and drainage, where we cannot do a surgery. For doing any surgery, the tissue should be firm to put incisions. But when there is abscess, we have to do incision and drainage so that the tissues will heal, and on a later date we can perform the full surgery. Okay, and we have a periradicular surgery, and as I told you, it is only adjunct to non-surgical root canal therapy. All these things, maybe 5%. And today also we are doing mostly these corrective surgeries, like perforation. If you are not very familiar with that, sometimes we create perforations, and mechanical also iatrogenic, and sometimes for internal resorption, external resorption, For periodontal management, we will do. And in case intentional reimplantation, we can use the surgery. And this slide is what are the this thing where and all you take, either it is anatomic or iatrogenic, we can do that. Okay. And the periodicular disease associated with the foreign body, we can do incomplete apexogenesis or blunderbuss canal, we can perform where the periapical seal is not correct. And if you want to take a biopsy of that area to differentiate between odontogenic keratocyst or OKC. Okay. So as there are contraindications for this surgery, emotionally distressed patient or psychiatric patient, and limitations in surgical skills of the operator and medically compromised patients, we cannot take up, or relatively contraindications. And local consideration, if there is acute inflammation, we cannot put incision. So only incision and drainage is done, started. And anatomical considerations, when the tooth is tip is near to the maxillary sinus mandibular canal, so it is not done, better avoided. Inaccessible surgical site, that maxillary tuberosity, like that areas, better not to venture. And tooth with poor prognosis, short rooted teeth, because we are going to cut the apical one third. Short rooted teeth is not a candidate for periapical surgery. Vertically fractured tooth, non-strategic and unrestorable tooth are not a candidate for periapical surgery. So patient evaluation and medication in this time of COVID-19, patient evaluation is important. So all these general things we have to take this thing. I'm not going to detail it because our oral medicine this thing. And we can give pre-medications. And this is the prophylactic regimen for dental procedures for high-risk patients. So pre-surgical investigations. So routine investigation, RBC, WBC, or this thing. So in this time of COVID-19, we can, if it is necessary, we can add COVID-19 also. And history taking is important before putting the patient for any surgical procedure. And coming to surgical instrument kits, most of them are known to us. It is nothing new. Maybe microscopic instruments may be new to us. So incision blades. What are the incision blades? Any idea? Anyone? Incision blades.
EP blade.
What is the number?
Like 11.
For putting the incision, we use 15. Putting the incision, we use a 15 number blade. Okay. Elevation instrument, retractions, curetouch instruments. We have got a bigger curettes. Okay. Osteotomy for cutting the bone. Inspection instruments, retrofill carriers to put the MTA, this thing, artery forceps, tissue holding, and suturing instruments, and ultrasonic instrument for retro preparations. Okay. All these things are there. So surgical instruments, all this instrument. So osteotomy instrument is a micro head handpiece where the angulation is slightly 45 degrees. So it will facilitate the cutting of the tooth, because the area of the root is very small. Okay. So artery forceps, all these things we have, you can use. So this is the armamentarium we are going to use. So these are all the micro instruments. You can see the mirrors here, very, very small, where you can use. And this is the hand piece. You can see the angulation. It is not like our regular contra angle. Okay, bond ranges are there. So all are the routine instruments only we are going to use. And these are all the retractors. Okay. So this is a routine armamentarium used, and we can see the micro mirrors here. 40 Vicryl is there for this thing. For osteotomy, burrs are there, corpules are there. So BP blades, everything is there. So this armamentarium setup is like that. I think we are familiar with almost all of the instruments except for this micro-sized mirrors and this thing. Okay, so as I told you, now two things only with the endodontic surgery. It is adjunct to non-surgical root canal therapy, and second, it is microendodontic surgery because of microscopes. Because previously it was not very precise and meticulous. Now it is, we can access that area very nicely with the use of a microscope and with the micro instruments. Not only microscope, micro instruments also is needed. And for retro preparation, retro filling, we have the best ultrasonic tips, and we have the better biologically accepted filling materials. When we are students, we used to fill that apical end with silver amalgam. Okay, but nowadays the material is MTA, mineral trioxide aggregate. Okay, so the surgical procedure is very fine with the microscope and with micro instrument. So we got a good magnification, illumination from the microscope, and better instruments gives a better results of the microendodontic surgery. So this may come as a short notes. What are the advantages of microscopic endodontic surgery? Traditionally, osteotomy size or the bone cutting, it will be 8 to 10 millimeter, and microsurgery it is 3 to 4 millimeter. Bevel angle degree, it is 45 to 65 degree because we cannot see the bevel given in the tooth. It is now because of microscope, it is 0 to 10 degrees. Inspection of resected surface, no, it is not possible. It has to be done empirically, and it can see the resected root surface always. Isthmus identification is impossible in traditional. It is always possible in the this thing root ender preparation. Never inside the canal, always within the canal because of the ultrasonic tips, and we can use it very precisely. So going to surgical instruments, I think we are familiar with all these things. For elevation and retraction, most simple periosteal elevator which you use in oral surgery is enough. And for removing the cortical, this thing, straight hand piece, burrs, hand chisel, saline, everything. Curettage is nothing but a big spoon excavator. Goldman Fox number 3 curettes you can use. And for retrograde filling, MTA carriers are available. Okay, so this is simple procedures where there is a swelling, we can do a incision and drainage. We can elevate and reduce the pressure in that area. This cortical trephination, because we cannot put incision on a abscessed surface or a swelling wherever it is, so we need to reduce the swelling. Okay, so I will go through the surgical procedure first. Depending upon the number of tooth, the flap design will be decided. So we have to expose the surgical site by doing a flap, and then incision, flap reflection, retraction, and osteotomy. So retraction should be very gentle because all this soft tissue anterior gingival area, and we have to curate that area. And as all of you know, the cyst will have a sac. Yes, the sac should be removed in toto and subjected to biopsy. And once the cystic sac is taken, we can see the apex of the tooth. Do episectomy, that is cutting 2 or 3 millimeters or 3 to 5 millimeter. We can cut in the apical region and give a retro preparation, and retro filling is done, and then flap closure. It is very important because we have to get the proper architecture after the surgery. So flap design, this may come as a short notes. This thing, very easy question if properly understood. Okay, so flap design should allow necessary bone removal, optimum vision, instrument access with minimal trauma to the tissues. Okay, so any flap will have a one horizontal incision and a vertical incision. One horizontal and a vertical incisions. Now it has added with intracircular incision. It allows for repositioning that help in wound healing. So the guidelines are given by the local anatomy. Shallow vestibule, it is very difficult to retract the flap, and flap should extend to 1 or 2 teeth laterally. Suppose you are working on 2-1 means you have to take support from either 2 teeth. So the flap should come around 1-1 and 2-2. Okay. So vertical incision should be sufficient allowed to retract to sit on solid bone, not on diseased bone. Solid bone should be there. And it's an old concept, base of flap should be wider than the incisal margins to maintain the blood supply. Okay, because the procedure will be roughly around 45 minutes. So what they felt is the base of the flap should be always wider than the incisal angle. Okay, and flap should follow the continuous curvature of the gums. Okay, and incision should be made with firm continuous strokes. So incision, you should feel the solid bone and then put, not over just over nicking over the gums. It should be firm continuous stroke for that the tissue should be healthy. Okay, and sinus tract is there, it should be included inside the flap, and never incision should be given on bony prominences as on canine prominence like that. And full thickness mucoperiosteal flap should be raised to maintain the integrity of the periosteum and postoperative healings. Okay, so I think what is this design called as? You can see some design here. Radicular eminences, yes. Radicular eminences. In denture, we used to repeat this. This is called as festooning, yes.
Yes, sir.
Yes, the festooning, what you do in full denture construction. So these are radicular. So incision should not be in the radicular prominences. Okay. And flap reflector should have broad enough visual this thing to see the surgical site. Okay, this is of a posterior tooth, mesiobuccal root. So incision should not be closer than 5 millimeter to a bony defect. You should be away from the lesion. So this may come as a short nose, different types of flaps. Is a single vertical, double vertical, scalloped or Luke ocean bean flap, curved or semilunar, gingival, mini vertical. 6 types are there. So there are line diagrams given in this so that you can draw it in the exams. So triangular flap. So mostly we illustrate with the anterior teeth. It consists of a one horizontal incision and only one vertical incision. This side it is not relieved. Okay. So one horizontal incision and one vertical incision make a triangular flap. So it is indicated in short roots. Okay, short roots. So we are all aware about the root length by taking that X-rays. And radicular repairs, any perforation like that, you can do with a triangular flap. No need to cut on the other side. If you cut on other side, changes into a rectangular flap. Okay, these are the triangular flap. One's horizontal incision and one vertical incision. So advantages, it can be easily modified. Suppose you want change into rectangular, you put a again one vertical insertion, you change into rectangular flap. Okay. So visualization of complete length of this thing, easily repositioned. Option for performing minor periodontal surgery. Mostly in case of labial perforation also we can manage with that. Okay. So these are all the disadvantages. Second is double vertical. As I told you, two vertical incision and one horizontal incision will make it as a trapezoidal or rectangular flap. This is a very commonest flap used in the endodontic surgery. So periapical surgery of multiple teeth, large lesion, long roots, where you really want to see all the roots and diseased area. Double vertical, trapezoidal, or rectangular is a flap of choice. So this is the line diagram. This is the horizontal incision and two vertical releasing incision. So one tooth lateral to the deceased tooth, you have to open it up. So that is these diagrams are very used to draw in the exams also. It is very easy to draw if you understand it. One horizontal incision and two vertical incision, and you get a full reflection, and you can see the base of the flap is broader than the incisal area. So to maintain the blood supply, it is open like that. So advantages is provides a maximum maximity and visibility, reduces retraction tension, facilitates repositioning because it's anterior teeth. Repositioning is very important. Retrofilling of long roots. Disadvantages because it is a long this thing, gingival recession, suturing, everything is a problem sometimes. And sometimes they'll ask about scalloped, low caution bean flap or submargin flap. So as by this time, all of you know, where is our work area? Suppose in this case, where is our work area? Where is the diseased tissue? It will be in the, is it audible? Hello? Where is our diseased area? It is in the apex. Yes. So suppose you are taking a bridge case, fixed partial denture of 6 teeth is there, and there's some cyst is here. And if you make a incision here, what will happen? There is a gingival recession may occur. So some dentists may not like that, and the patients also doesn't like that. So you can start from the away from the free gingival margin. Okay, and our work area is definitely is not this. So they start the horizontal incision from here and do this. So this is called a scalloped. So it is in attached gingiva so that parallels the free gingival groove. So aesthetics is not hampered. That is one of the main thing. And all of us know our work area is in the periapical region only, not in the free gingival area. So disadvantages is difficult to alter and disruption of blood supply. So semilunar is one of the oldest flap, still also you can see some patient with some scarring in the periapical region. So in cases of crown where present small lesion trephinations, and if you are correctly know about that area, you can do that, but it usually heals with scarring, but very conservative design. Okay, aesthetics not hampered because the incision or crescent-like shaped semilunar is given in the apical region only. Mostly the problem is healing with scarring. That is the only major disadvantages with that. Gingival flap used in perio for small periodontal procedures, we can use that. So mini vertical for any trephination, minor curettage we can use. Okay, small procedures we can use. Okay. So at least by understanding this, you can draw these line diagrams in the exams. It is easy for you to different types of flap, trapezoidal flap, rectangular flap, triangular flap, ocean bean loop flap. So this is line diagrams. At least we expect you to draw in the diagrams if the flap designs questions is asked. So going to the surgical techniques. So infiltration is the very commonest technique. Okay. So this all the where and all you can give infiltrations. So incision, as you know, it now done with the number 15 blade. Okay. So elevation and reflection. So mostly we use a periosteal elevators. Okay, blunt end is used to reflect the full thickness mucoperiosteal flap. So always tissues should be supported with periosteal flap so that other tissues are not injured. So osteotomy burr. So you have to cut the bone to locate the apex of the or the root tip of the diseased tooth. Okay. So you can do with a lot of irrigation, saline irrigation to reduce the cooling and which will improve the bony healing. And periapical curettage, as you see, this large size spoon excavators. So according to the lesion size, you can use inside the this thing, and you have to remove the cystic sac in toto to give it to biopsy. Okay. So you should have a biopsy bottle nearby to you when you're doing a periapical surgery. So once everything is over, you have to do the root resection and retrofilling. Okay, and suturing is done, and this will how it will look like after the surgery, because you can see the tip of the roots are cut and there is a retrograde filling material placed there. So what is the rationale behind episectomy? So sometimes you get a what is root resection, what is retrograde filling? You can
necessary canals.
hello. So what is the rationale of the episectomy is, this is how it is given. So minimum 3 millimeter that require at 0% 0-degree bevel eliminates most of the anatomic features. So the lateral canals are very common in the upper central incisor as well as in any tooth. So if you cut up to 3 millimeter, it eliminates most of them, and then we have to have only one root canal where you can do a retrograde filling and get a hermetic seal. So that is the idea of doing the episectomy and retrograde filling. If you, without cutting anything, you put a retrograde filling, maybe you have to answer for all these lateral and accessory canals, which is not possible. So better to cut at 3 millimeter, and then you can seal it, which is mostly proven. 3 millimeter will be the better choice. So before starting itself, you should inform the patient what are all the post-operative sequelae. Definitely get a swelling. Yes, anterior teeth, wherever you're touching the bone, definitely you'll get a swelling. 1 or 2 days it will be there. It should be informed prior so that patient will also plan his routine. So swelling will be there. It is not magic swelling. If you touch the bone, there will be some amount of swelling will be there, which should be informed pre-operatively. And some amount of pain is expected because of the tissue retraction and the swelling and edema. Some amount of ecchymosis or the reddening of that area will be there. Sometimes you get paresthesia if you are coming near to any vital nerve structure. Sometimes transient paresthesia may be there. Okay, stitch abscess, yes. Hemorrhage, of course, any surgical position, post-operative instruction should be given clearly. What you give for extraction should be given. Should not spit, gargle, should not take any hard foods, and like all this, should not spit like that. Sometimes perforation can occur. Iatrogenic damage to the adjacent tooth while cutting the osteotome. Sometimes incision failures. So most commonly what we will come across is swelling and pain and ecchymosis are very common. So patient should be informed priorly so that it will be useful in the post-operative sequelae. Okay. So instruction, since you anticipate some swelling, you can apply ice to the face for 20 minutes, and precautions to taken to prevent suture tearing. Okay, otherwise the patient will retract and see, and which will cause a suture tearing. So ask the patient not to retract the lips and show to everyone so that suture will be intact. Should not take any gritty food or hard food, soft food. And after 1 day, you can use warm saline gargling. And for antibiotics and painkillers can be used. Okay, so repair, what you anticipate after 1 year or 6 months. So if you take X-ray, there should be a complete repair with restoration of patient with minimum or no inflammation. Repair with scar tissue with moderate inflammation, you can anticipate. Okay, so there are some other endodontic surgery other than periapical surgery. Reimplantation, which is very commonly done, Abel's tooth, we have to keep inside the patient socket, and again we have to use it. Okay, so mostly we come across the accidental avulsion, very common in the uh, young group. Okay, so contraindication, if it is severe periodontal disease, no. Curved and flat canals, no. Non-restorable tooth, missing interseptal bone, transplantation. So these are all the relative contraindications. And tooth should be extracted with minimum trauma and to the socket. And ideally, elevators are not used. And as all of you know, the storage media will be HBSS, Hank's balanced salt solution for Abel's tooth or any tooth to be extracted. Okay. And after root and preparation, filling tooth is placed back in socket. Root amputation and resections, because nowadays root canals are very common. Suppose one root is severely damaged or we cannot resolve that problem, better to cut that root alone and retain the other root for survival. Okay, so indications of existence of periodontal bone loss to extend the periodontal therapy and patient maintenance not sufficiently improve the condition, and there is a resorptive purpose, surgically inoperable roots that are calcified, and the fracture of one root that does involve the other. Okay, so if you want to save one root, you can do the root amputation or resections. So two things are there. One is root amputation, other is hemisection. Hemisection means one half of the tooth is cut to retain the better other half, so that you can change a molar into a premolar. And third one is a to maintain the furcation, we can what we call as bicuspidation, changing a molar into two premolars, so that the furcation area is maintained well by the patient. So these are all other surgical endodontic procedures which is done. Okay. So this is root amputation for molars. Suppose three roots are there, one root is diseased, we can cut one root which is diseased. Sometimes mesiobuccal canal or it is calcified, some instrument separation is there which we cannot do. We have to recontour the crown at the point of root amputation, because other two roots are there which will survive and retain the tooth. Okay, so we can use plain Fisher burrs and you have to reshape it. So hemisection, cutting the one root and taking it out. Okay. So like that, other endodontic procedures like root amputations, hemisection and bicuspidizations are done. The most commonly performed endodontic surgery will be a periapical surgery with root resections with retrograde fillings. So sometimes you get a questions like how do you do a perform a periapical surgery in a upper central incisor, or how do you manage a blunderbuss canal, or what are the flap designs. The most common questions are what are the flap designs, or what are other endodontic procedures. Sometimes you maybe have to write about Abel's tooth. So I mean traumatic injuries, the Abel's tooth will be fully handled, but the surgical part of it only is discussed here. Okay, so any doubt regarding this? Any doubt? Hello.
No, sir.
Okay. So once again, I'll repeat the salient features. May not be given in some textbooks because it is only used as a adjunct nowadays. Adjunct or to support the non-surgical root canal therapy. To 5% of the cases, we are doing endodontic surgery, and with the microscope, it is most aptly called as endodontic microsurgery. Okay, and retrograde fillings, maybe you may get a questions. Retrograde fillings, the most commonly used retrograde filling nowadays is MTA and biodentin. Previously, we are using silver amalgam composite, GIC, IRM, like that, but the contemporary materials are MTA and biodentin. Maybe you'll get a short notes on retrograde filling materials. Retrograde filling materials. Okay. So that's all about endodontic surgery. So it's a definitive question, or at least a short notes will come from this topic. So one of the very commonest topics. You can see it in the our OP also. It is done then and there. Okay. So can I end the meeting? The time is getting lapsed now.
Okay, sir.
Okay. So this is one of the differences between root amputation, hemisection, or bicuspidization. And this diagram, I request all of you to draw if the question comes for episectomy. And this diagram is also very important if designs of flap in endodontic surgery. So these are all simple line diagrams. I request all of you to go through once. So there is a one horizontal incision and two vertical releasing incisions are given. So at least to illustrate your answers, this must be there. That line diagram should be there. So we are running short of time. So I will end this meeting now. If there are any doubts, you can put it in the WhatsApp group. Okay. Okay. Thank you all.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you, sir.